I welcome you all, my dear wonderful learners, on Dr. Reena's Physiology Core Crisp Integrated. And today I'm going to again take a session on a case-based learning. Before that, let me tell you my Telegram group, that is Physiology Synapse to Success. So please log in if you haven't. Help me to make physiology easy and accessible to one and to many, many, many. Right? So I provide the notes over here. So whatever notes are there will be provided to you. So please ensure that you are already in the Telegram group. Now this case-based learning is, or the problem-based learning is very essential for the first prof. Not only to clear your examination because it comes as a question, but you know that the next exam, the exit exam which you will be giving, it will be having integrated and it will be having conceptual questions, right? So you will have to correlate your basics with your clinicals, taking physiology from classroom to clinics. So that is the purpose of the case-based and the problem-based learning, which is not taken anywhere on any platform, and that is just introduced by me for all my loving learners. So let's get started with this case. I will not tell you what the case is related to. You just try to find out the answer. There is a 13-year-old boy who is brought to the pediatrician by the mother because he has got some concerns about growth. The patient is taller than the other classmates, has got coarse facial features, has got a prominent jaw. Both parents are short in stature and his growth is very abnormal as compared to his family members, or in comparison to his family members. On examination, extremely tall for his age with frontal bossing, hand and the foot size increased, coarse facial features, prominent jaw and a large tongue. Now, what is the diagnosis of this patient? What is the diagnosis of this patient? How are you going to approach? The first thing to be approached is age. The age of the boy is 13 years. That means that age where the bones ka fusion, yeah, the epiphysis ka fusion has not taken place. That means still there is a possibility of linear growth. Second, parents are short in stature. So if both the parents are short in stature, the boy, according to the constitutional growth, will not grow very tall, isn't it? It is inheritance. So he is not supposed to grow very tall, but he is going very tall. Now something which is confusing over here is hand and foot size increased and the coarse facial features and prominent jaw, which confuse us what it is. That means whether it is acromegaly, whether it is gigantism, because both of them are due to increase in the growth hormone. And you can see acromegaly will also show you the same features: increased size of the hand, hat, ring size, the the shoe do not fit into the foot. So the only thing which is very, very clear and which is not going to confuse is the age. So looking at the age of the person or the age of the boy, it is very clear that it is gigantism because of excess of the growth hormone. Don't get confused with the tongue. Enlarged tongue, soft, the soft organs, the tongue, the liver, they are also known to be enlarged or hyperplasic with your growth hormone. So just how does somatostatin inhibits the growth hormone? This is the question, and we come to the inference that there is a 13-year-old boy who has got abnormal growth and therefore he is gigantism and not acromegaly, looking at the age. How is inhibition of growth hormone? We will study in detail, but to complete as a one-liner, there are something which are called as somatomedins that stimulate the production of somatostatin. That somatostatin directly acts on the anterior pituitary to inhibit the growth hormone. So don't get confused. अभी बिल्कुल confused मत हो जाओ. Somatomedin क्या है? Somatostatin क्या है? We will clarify all of these. So how to approach with growth hormone physiology? What are the objectives? You must know the growth hormone what is the type of the hormone, how it is secreted, what is the mode of action, what are the physiological effects, and how is it regulated, because this itself is going to be a part of your LAQ. This is your LAQ. Now, what is growth hormone? Whenever you are studying any hormone, I always tell you, सबसे पहले जो आपको बात याद रखनी है, which type of hormone is it, what type, that means lipid soluble है कि lipid insoluble है, तो this is a protein hormone, PPP, hormones coming from the pituitary, pancreas and parathyroid are protein hormones. Pituitary, pancreas, parathyroid are protein hormones. Clear? Because it is a protein hormone, therefore it is lipid insoluble. Lipid insoluble, that means it cannot penetrate the cell membrane. So the question, where are the receptors? So the receptors definitely are going to be on the cell membrane. So I covered 2 to 3 MCQs. It is a protein hormone. Receptors are on the cell membrane. Now what type of its mechanism of action? Its mechanism of action is enzyme linked, which we classify as 2D type of mode of action. 2D. There are type 1 growth, there are type 1 hormones which are lipid soluble, that is your thyroid and your steroids, and there are type 2 which are water soluble, and they have got different mechanism of actions, A, B, C, D. So it is type 2D, which is enzyme linked, which is using tyrosine kinase. Okay, that is a part of this Janus kinase. So it is using Janus kinase. So it is a family member of this tyrosine kinase associated receptor. So the best answer for growth hormone is JAK, that is the Janus kinase. And if only tyrosine kinase is given to you, nothing related to Janus, it will be more for insulin. So remember that. Now this you have seen that this is the growth hormone, which is binding to an extracellular site, and this is an integral kind of a protein. So the growth hormone receptor has got an extracellular domain and intracellular domain, and we can see that the intracellular domain is associated with your Janus kinase. So the hormone is going to bind on the extracellular domain. See, this is the hormone which is binding on the extracellular domain. As soon as it binds, it leads to receptor dimerization and activation of the tyrosine kinase in the associated protein. So जैसे ही hormone will bind on its extracellular side, there is, you can say, dimerization of this protein का associated protein, that is the Janus kinase. The associated tyrosine kinase is going to phosphorylate itself, the hormone receptor and the other protein. So ultimately what happens? Binding of the growth hormone to its receptor, dimerization of the receptor, activation of the tyrosine kinase in the Janus kinase, and transcription of proteins, mRNA and new protein synthesis. So remember, in 4 steps, binding of growth hormone to its receptor, right? Growth hormone will bind to its receptor. As soon as it binds, there is receptor ka dimerization. Okay, there is receptor ka dimerization. There is followed by phosphorylation. Right after phosphorylation, there is transcription of mRNA, and this is going to result in new protein synthesis. So these 4 steps, just remember, this is what you must remember, and एक flow chart में बना दो, हो गया आपका answer. Now this is the regulation of the growth hormone. So it is an example of a negative feedback mechanism, right? It is an example of a negative feedback mechanism. Now you know that growth hormone itself is coming from the anterior pituitary. Acidophils, which cells in the anterior pituitary? They are the acidophils which secrete growth hormone, which is under the control of regulatory hormones coming from the hypothalamus. The hypothalamus secretes 2 regulatory hormones. One is GHRH, that is the growth hormone releasing hormone, and the other is the growth hormone inhibitory hormone. Growth hormone inhibitory hormone, which is somatostatin. The same somatostatin which also comes from the delta cells of stomach. It also comes from the delta cells of stomach. It also comes from the pancreas. It is a total inhibitory hormone. So कभी भी MCQ आता है inhibitory hormone और अगर somatostatin दिया हुआ है blindly you can tick on. It is everywhere inhibitory. So hypothalamus is releasing growth hormone releasing hormone which will stimulate the anterior pituitary, and growth hormone will be released which will bind and act on the target tissues. It also secretes somatostatin which will also act on the pituitary and inhibit the release of the growth hormone. Apart from this, there are target tissues, especially liver, which synthesize somatomedin. This somatomedin is nothing which is called as insulin-like growth factor. Okay, it is insulin-like growth factor. This insulin-like growth factor or the somatomedin increases the synthesis of somatostatin. And somatostatin then inhibits growth hormone. That means somatomedins also provide a negative feedback mechanism via somatostatin to inhibit growth hormone. So I repeat, growth hormone का जो release है anterior pituitary से, it is controlled by two hormones जो आ रहे हैं hypothalamus से. Growth hormone releasing hormone, growth hormone inhibitory hormone, that is somatostatin. Somatomedins are synthesized from the liver. They are also called as insulin-like growth factors. और ये क्या करेंगे, ये somatomedin का production बढ़ाएंगे. Okay, these somatomedins will increase the production of somatostatin. Somatostatin फिर क्या करेगा, will inhibit growth hormone. Now, what are the actions of growth hormone? So I have taken it in the form of a table. You can elaborate when you get an LAQ. If you are just getting a case study, that means 5 marks का question है, तो ऐसा भी लिख दिया तो sufficient है. Now, growth hormone increases the release of insulin-like growth factor. This is called as insulin-like growth factor. That is our somatomedin. The somatomedin also mediates some action of the growth hormone, especially skeletal growth. So this becomes my MCQ, right? The effect of the growth hormone on the skeletal growth, that is on the epiphyseal growth, is brought about via somatomedins. Very important effect of growth hormone is protein synthesis. It is anabolic. This action of the growth hormone is synergistic with insulin. That means growth hormone and insulin coming from the pancreas work together to increase protein synthesis. Apart from this, it is known to bring about lipolysis, sodium retention, but it is a hormone that brings about hyperglycemia. Hyperglycemia. So stressful condition में, fasting, starvation में growth hormone is released. But ये क्या करता है? It also causes a decrease in the insulin sensitivity. It decreases the sensitivity of the target tissues to to insulin. That means in some cases it is behaving as anti-insulin. It is sharing protein synthesis with insulin, but glucose ka level it is increasing by decreasing the sensitivity of the tissues to growth hormone, to insulin, decreasing the sensitivity of the tissues to insulin. So it is anti-insulin. So what does it do? It causes increase in the glucose level. Therefore, if the patient develops acromegaly, okay, if the patient develops acromegaly, or if the patient has got abnormally high level of growth hormone, this patient can develop diabetes mellitus. But this diabetes mellitus is not going to improve with insulin, because insulin is not the reason over here. So this is called as insulin resistant diabetes mellitus. Insulin resistant diabetes mellitus, which is not because of deficiency of insulin, but it is because of excess of growth hormone, and therefore it is also called as a pituitary diabetes. It is called as a pituitary diabetes. Why a pituitary diabetes? Because this diabetes is not caused due to deficiency of insulin. It is because of excess of growth hormone. So excess of growth hormone can result in diabetes because it causes hyperglycemia. Not the normal level. Every one of us are going to increase the growth hormone, but not normally. Only when it is more than the physiological doses. So these actions, that is protein synthesis, epiphyseal growth, lipolysis, anti-insulin, sodium retention, must be remembered to cover your points. Apart from this somatomedin or the insulin-like growth factor, this has got important factors or the important effects, like it is insulin-like activity, it causes protein synthesis, it is epiphyseal growth needed factor, and it is anti-lipolytic. Growth hormone itself is lipolytic, it is going to cause the breakdown, but this will not cause the breakdown. Okay, so it is anti-lipolytic. Now there are n number of factors which can increase the growth hormone secretion. I have given you in the form of a table, but what is expected from you? Remember, growth hormone will be released in the body at the time of growth spurts. Whether this growth spurt is during infancy, whether the growth spurt is intrauterine, right, or whether it is puberty. After adulthood, okay, the level of the growth hormone starts declining. So these are the conditions where the growth is needed. Apart from that, the important physiological factors where you need growth hormone. Any condition where the glucose goes down, ऐसे याद रखो. तो glucose कब कम होगा? When there will be hypoglycemia? Exercise, fasting, whenever there is increase in the proteins in the diet, because the proteins they cause, whenever the proteins are secreted, these proteins will be assimilated as amino acids, and you have to again synthesize them as the body proteins and store them, which is the function of the growth hormone. So a protein meal increases growth hormone. Sleep, with sleep is NREM. NREM sleep increases growth hormone, whereas the REM sleep decreases the growth hormone. Apart from that, you can remember estrogens, androgens, any stressful stimuli, whether it is trauma, whether it is a physical stress, whether it is a mental stress, anything, and emotional stress, they are going to increase the level of growth hormone, right? So stress, starvation, exercise, hypoglycemia. Don't mug up. I always tell you, endocrines are a lovely topic to be remembered, just like a story. So you are exercising, glucose level is going down, growth hormone will be released because it causes hyperglycemia and lipolysis to provide nutrients, right? And decrease, remember, REM sleep decreases the growth hormone, right? Apart from this, if there is glucose, if there is already free fatty acid, if there is already cortisol, these are also going to decrease the growth hormone. One important thing, these pictures, they come in your experimental practical which we give you, identify. So remember, this is a short stature. You have to identify this. This is gigantism. And you would not say that this is short stature and this is hyposecretion of growth hormone. You can see an abnormally linear increase in the height. So this is gigantism. I differentiate it from acromegaly, because in acromegaly, what is important feature is broadening of the facial features, frontal bossing. Look over to the nose, look over to the maxilla and mandible, more of this bossing. So that what differentiates your growth hormone excess before puberty and after puberty. So let's try to wind up with one MCQ. The actions of the growth hormone on the skeletal system are mediated by insulin, somatomedins, thyroid hormone and estrogens. So just now I told you that the effect of the skeletal system, that is your growth, is brought about by somatomedins. So before we conclude, an important motivational mantra always I believe that I should imbibe to my students: self-discipline. Self-discipline. Nobody should tell you do this, do that. Why should I tell you do this, do that? You are grown up. So the first important quality, if you love yourself, should be self-discipline, because that is the magic power which will help you to acquire whatever you want, and you will be really unstoppable, right? Unstoppable. So what quality we have to acquire is self-discipline. Thank you for your patient learning. Hope you like the lecture. Please ensure you put a like and you put a comment over it. Thank you and God bless you.